Okey-doke. What's up, guys? Sorry I'm a little late, and sorry that it's not Sunday night, it's Monday night. Last night, so normally on Sunday nights, my wife puts our daughter down for me, and my wife was not able to do that last night, and so I was in there for a long time getting Amelia down, and now I was just a couple minutes late here because exact same thing. My wife's at book club tonight, and I'm working on getting Amelia down. So, but tonight we're gonna go over cranial nerves, pediatric milestones and reflexes, and I think what that last one was. Lost. Lymphatics. Right. Okay, so we will go ahead and get started here in just a second. I'm going to give a little bit of time for people to join in if they want. And while I'm doing that, let's see if I can get this poll up. All right, so I want to know who would be likely to, or more likely to engage in the content if I created a Kahoot, right? And so really what I want to know is if I did a Kahoot, would you be more likely or less likely to engage in the material? So if you would be more likely to engage in the material, give a smiley emoji. If you'd be less likely to get engaged in the material, give a crying face emoji. The big thing logistically that I'm thinking about in terms of doing a Kahoot is that if we did the Kahoot, you would have to have two screens up, right? So you'd have to have the live on like your phone or your computer, and then you'd have to have the Kahoot set up on the other one, right? So you'd always have to have two screens up in order to be able to do that effectively. So I was just thinking about it today because at least with Kahoot you could be like anonymous, but then I'm like, I don't know how likely people are to jump on two different devices at once. But anyway, so I was just curious about that because I might be thinking about doing that in the future. But I don't know. Let's go ahead and jump right on in to our first question. A patient following a TBI demonstrates an inability to elevate the shoulder against resistance and difficulty turning the head to the contralateral side. Which cranial nerve is most likely impaired? A. Cranial nerve 10, B. Cranial nerve 11, C. Cranial nerve 9, or D. Cranial nerve 12. You guys take some time to respond. I want you guys to be engaging in the questions, right? And so give it your best shot based on what you know about cranial nerve assessment and innervation. And then we will jump in to the answer here in just a bit. While you guys are answering, I'm going to go grab a bottle of water. So give me just 1 second. All right. So, looks like most of you got an answer in. Let's go ahead and reveal the answer. And you guys are absolutely right. It is the accessory nerve. So, accessory nerve is going to innervate sternocleidomastoids and trapezii, if that's the right way to say it. So, those are going to be responsible for our head rotation and shoulder elevation. Cranial nerve 10 is the vagus nerve, and that's going to be responsible for controlling swallowing, voice, and parasympathetics. Cranial nerve 9 is your glossopharyngeal nerve, which is going to control taste to the posterior third of the tongue and your gag reflex. And then cranial nerve 12, your hypoglossal, is going to control your tongue movement. So, good job, guys. We'll go on to number 2, a PT. Guys, quit, please. Hey, Blue, go to bed. Go to bed. A PT lightly touches the patient's cornea with a cotton wisp and observes no blink response in either eye. Which cranial nerve provides the afferent limb of this reflex? Ria, we don't do Mondays. I meant to do this yesterday, but my wife was not able to put our daughter down for me, and so I put our daughter down, and that pushed me to not be able to do it on Sunday. So this is an exception. I'm substituting Monday only this week, so that way I still get it in this week. Let me reread that question. A PT lightly touches the patient's cornea with a cotton wisp and observes no blink response in either eye. Which cranial nerve provides the afferent limb of this reflex? A. Cranial nerve 5, B. Cranial nerve 3, C. Cranial nerve 7, or D. Cranial nerve 8. I upload the lives on YouTube. Yeah, Josiah. Yeah, you got some time to answer still. All right. Only have a few people answer this one, which means I must have written a really good question. I'm gonna give you guys a little bit longer. I want to see a few more answers before we reveal this answer choice. I'll wait. Okay, let's go ahead and go over it. So the answer choice, or the correct answer, is cranial nerve 5. So your trigeminal nerve is going to provide the sensory input from the cornea for the corneal reflex. Okay, so it's asking afferent limb, right? So A, afferent means sensory, E, efferent means motor, right? So eye movement and pupillary restriction is going to be controlled by B, your oculomotor nerve, C, your blink motor response, which is cranial nerve 7. So to touch and feel. F, facial. So facial is going to be the motor output, which actually causes the blink response, right? So that's the efferent portion of the corneal reflex. Um, and then D, cranial nerve 8, is vestibulocochlear. That's going to be responsible for hearing and balance, which isn't going to have anything to do with corneal reflex, right? Does that all make sense? Enough anyway? And guys, um, feel free to share this if you guys have classmates or you have people in other cohorts in different schools that you feel like would benefit from this sort of thing. Clear as mud, Hannah said. Yeah, good question. So your corneal reflex is going to be two separate things, right? So you get a stimulus to the eye, which could be like blowing in your eye or putting the cotton ball, right? And so the afferent or afferent um, point or the sensory input has to go through one nerve, and then you have to have a motor output of a different nerve. So we have some that are going to do right both motor and sensory, but in this case, with the corneal reflex in particular, you've got the afferent or afferent response going in, um, or the afferent input going to your eye, to your brain from your eye, and then the motor output is going to be facial. So that one's just a little bit more nuanced question. Um, yeah, Vani, you're right, and Ria, you're right about that too. Okay, let's go on to number 3. During a neurological exam, the patient's tongue deviates to the right when protruded. Which nerve lesion is most likely present? Right cranial nerve 12 lesion, left cranial nerve 12 lesion, right cranial nerve 9 lesion, or left cranial nerve 9 lesion. Read it one more time. During a neurologic examination, the patient's tongue deviates to the right when protruded. Which nerve lesion is most likely present? A, right cranial nerve 12 lesion, B, left cranial nerve 12 lesion, C, right cranial nerve 9 lesion, or D, right cranial nerve 9 lesion. Give you guys some time to respond. Okay, I got a few people that think A. Anyone else want to give it input to number 3? Okay, Andrew says B. Give a little bit longer, maybe have one more answer choice and then we'll go. Okay, let's go over it. So the answer is A. The hypoglossal nerve is going to control tongue movement, right? So if you have a unilateral cranial nerve 12 lesion, your tongue is going to deviate toward the side that is affected. The reason that is because your genioglossus, which is the muscles that control the tongue, right? So if I have muscles working on the left side and I stick my tongue out, but I don't have any counter pull from the right side, it's going to deviate to the right side, right? And so if I had a bilateral cranial nerve 12 lesion, I would have a difficulty with tongue protrusion altogether, right? But because it's unilateral and it's deviating to the right, then the lesion has to be on the right because you don't have that effective push from both sides to keep the tongue from deviating one way or the other. There's a mnemonic. Lick the lesion for this cranial nerve. Yeah, nice. I haven't heard that one. Uvula is the opposite. Absolutely right. And that is controlled by which nerve? Deviation of the uvula is controlled, or would be a lesion of which nerve? 10. Vagus, yep. Let's see. I always have to go through them. To touch and feel very green. Vegetables. Yeah, vagus nerve. Cranial nerve 10. Because 9 is to touch and feel very green. Glossopharyngeal, right? And so that's going to be more posterior third of the tongue. Taste and gag reflex, glossopharyngeal. Okay, number 4. A patient reports double vision when attempting to look downward and medially. Which cranial nerve is most likely involved? A. Cranial nerve 3, B. Cranial nerve 4, C. Cranial nerve 6, or D. Cranial nerve 2? A patient reports double vision when attempting to look downward and medially. Which cranial nerve is most likely involved? A. 3, B. 4, C. 6, D. 2. Okay, we got several people tuning in with the answer B. B, baby. Give a little bit longer. Okay, looks like the answer choices are coming in slower, so let's go over it. All right, so the trochlear nerve or cranial nerve 4. Okay, let's talk about why. So your trochlear nerve is going to innervate superior oblique, right? And superior oblique results in depression and intorsion of the eye, okay? So if I'm looking downward and medially, or think about like if I'm looking towards the tip of my nose, right? It's bilateral superior obliques that pull me down and in, okay? Sorry, it pulls me down and in, but the muscle goes like that. So, um, while you might have some oculomotor input or like contribution to the rest of the muscles that help get you there, it would be much more obvious in other areas like looking up, looking down, looking medially, right? And then lateral rectus, if that was affected, we wouldn't be able to pull laterally, which would be abducens nerve, right? So your oculomotor nerve is going to control most eye movements, but not primary depression in adduction. And then abducens controls lateral rectus, like we said, and then D, cranial nerve, is going to just control vision in general, not oculomotor movements. Okay? And now number 5, our last cranial nerve question. A patient presents with facial droop, inability to close the eye, and loss of taste on the anterior 2/3 of the tongue. Which cranial nerve is affected? A. Cranial nerve 5, B. Cranial nerve 9, C. Cranial nerve 10, or D. Cranial nerve 7. Yeah, you're absolutely right, Lonnie. So abducens, I think abduct, right? Okay, awesome. If you guys are new here, by the way, my name's Austin. I didn't realize I didn't even introduce myself after the room started filling up. My name's Austin. I am a neurologic physical therapist here in Northwest Arkansas. I primarily work with, obviously, I work with neurologic populations, but I primarily work more with vestibular and concussion rehab patients these days. Um, and for whatever reason, I end up seeing a lot of the spinal cord injury patients in our clinic as well. But I see everything, really. And I just like to make NPTE practice questions. So this is what I do. Normally, I do this on Sunday nights. I wasn't able to do. OMG, Austin, we're both in Arkansas. Heck yeah, dude. Have we talked about this before? I feel like we've talked about this before. Unless there was another fielding DPT sometime. But anyway, I normally do this on Sunday nights. I wasn't able to last night, so I kicked it to tonight so that way I could still get it in for the week and not waste everyone's time. But so looks like a lot of us are answering with cranial nerve 7. Let's talk about it. Facial nerve. Very good, guys. So facial nerve is going to control facial expression, taste on the anterior 2/3 of the tongue, and then your lacrimal and salivary glands, right? So lacrimal glands, obviously, working on, uh, thank you, about to be a third-year PT student, and I'm super nervous to start studying for boards. Well, weren't we all at one point or another, right? But you'll get through it. We all do, and then you'll be a PT on the other side of it. I just want to be here to help give you guys that little push over the cliff if I can, give you some extra free resources to study, and so this is what I do with my time. Instead of, I don't golf, I don't fish. I would love to go fish, but I don't do that as much anymore because I have a 2-year-old that I'm raising. And so what I do have time to do is type questions up on my computer. Anyway, so lacrimal, obviously tear glands, salivary glands. Cranial nerve 5 is going to control facial sensation and your muscles of mastication, but it's not going to be the ones that primarily control the entirety of your face musculature. B is going to be posterior tongue taste. We talked about that. Glossopharyngeal. And C is going to be swallowing and voice. Cranial nerve 10 is going to be your vagus nerve. And so, good job. We got through the cranial nerve questions. Now we're going to move into developmental milestones and reflexes. So, I usually try to do 3 topics a night just to try to span a wide range of topics every week, 3 topics every week. And so this week we're going over cranial nerves, obviously, reflexes and developmental milestones, and then number 3 is lymphatics. So starting at question 11 through 15, we'll do lymphatics. So number 6, a physical therapist assesses an infant and observes the Moro reflex when the infant's head is allowed to fall slightly backward. At what age should this reflex normally disappear? A, 12 months, B, 6 months, C, 4 months, or D, 2 months. A lot of these reflex and milestones questions, when I was studying for my boards, was just a matter of drilling it, and I would write it out 100,000 times. It felt like I just got on a whiteboard in my PT classroom and I just wrote them all out. And then my buddies and I would just drill them, and we try to come up with the most ridiculous mnemonics possible just to be able to memorize them. But that was 4 years ago, and so a lot of this stuff I have to look back up in textbooks because I don't work with the pediatric population. A few of you saying C. Give you guys a little bit more time to respond, and then we will open up that dark highlight. And like I always say, guys, don't be afraid to just respond with your answer choice. There have been really good studies that have shown the more we engage in material actively rather than passively, the better connections we're wiring in our brain to remember those things. And so, for instance, if I'm just listening to something, even though I'm an auditory learner, if I'm just listening to something passively, I'm much less likely to be able to remember those things than if I'm actively engaging in it. So that would look like I'm listening to it and then I'm also reciting it back to myself, right? Or I'm writing it out as I'm listening. Some sort of active engagement actually allows my brain to make those connections so that way I can recall that whenever I get tested on this sort of stuff. So the answer is C. Okay, I don't really have a big explanation for this one. That's just generally it disappears by 4 months. So like I said, with all of these reflexes, in terms of when they integrate, you want to just write them out and just try to, like, we used to go through a list of like 1 month, this is the stuff that goes away. 2 months, this is the stuff that goes away. It's because there's, at certain points, there's several that will integrate. And so Moro has 4 letters. That's a good way to remember it. Moro has 4 letters, 4 months. Nice. I'm kind of out of that study habits, right? I don't have the silly mnemonics that I used to have because I don't have to do this anymore. And one day, neither will you. Number 7, an infant is placed prone and demonstrates the ability to lift the head to 90 degrees and support weight through the forearms. What is the most likely age? A, 1 month, B, 2 months, C, 3 months, or D, 6 months? Okay, we got one person. Good. Oh, Hannah, pick one, girl. Oh, user. Okay. All right. So this is a typical 3-month milestone. Okay. So the answer is C. A and B, they'll probably only be able to get their head to about 45 degrees. And then D, uh, they should be able to get extended arm support and pivoting at this point, right? So like being able to pivot on their belly or something and turn to grab things. To address your question, user 768, big number. If I have gotten this wrong in terms of sourcing, there are multiple sources that are going to say different things. The most consistent source that I use is the Score Builder Study Book, which has uh, suggested that the Moro disappears around 4 months. Okay, number 8. Which reflex is elicited by stroke of the lateral border of the infant's foot, producing toe extension and fanning? Which reflex is elicited by stroke of the lateral border of the infant's foot, producing toe extension and fanning? A, plantar grasp, B, Babinski, C, ATNR, or D, Gallant? Right? Easy peasy, guys, right? This one's the easy one. Good job. Absolutely. Babinski. So your plantar grasp is going to be a response that sounds like exactly what it says. They're going to get that grasp of the toes, so you're going to get toe flexion, right? ATNR is the fencing posture, which is totally unrelated to stroking the lateral border of the foot. And then Gallant produces trunk curvature, so that's more like producing that side flexion in response to a stimulus. So they stroke one side, like you stroke one side of their abdomen, and they flex or side flex to that side in response to the stimulus. That's the Gallant sign. Number 9. Which developmental milestone is most expected at 9 months? A, roll supine to prone, B, walk independently, C, jumping in place, or D, independent sitting without support? Which developmental milestone is most expected at 9 months? A, rolling supine to prone, B, walking independently, C, jumping in place, or D, independent sitting without support? Okay, jump into it. All right, yes. So independent sitting without support typically happens between 8 and 9 months. A is going to happen approximately between 4 and 5 months. B is going to happen at 12 months, and jumping in place really won't happen until the toddler stage. So one more question in pediatric milestones and reflexes. Number 10, when the infant's head is turned to one side, the arm and leg on that side extend while the opposite side flexes. Which reflex is being demonstrated? A, STNR, B, ATNR, C, TLR, or D, Moro? Okay, very good, guys. You're absolutely right. ATNR, asymmetrical tonic neck reflex. So your STNR is going to be a flexion extension pattern in crawling. C is going to be more of their posture relative to gravity, and then D is the startle reflex, right? So very good. Fencing posture, that's absolutely right. Okay, last 5 questions of the night. Number 11, which structure is responsible for filtering lymph and initiating immune responses? Hold on, that's going to bother me. Initiating immune responses. A, lymph node, B, thoracic duct, C, cisterna chyli, or D, lacteal? Which structure is responsible for filtering lymph and initiating immune responses? A, lymph nodes, B, thoracic duct, C, cisterna chyli, or D, lacteal? All right. Yes, guys, sometimes you just got to go with your guts. And the answer is A. So your lymph nodes are going to filter your lymph. They also house lymphocytes and macrophages for immune defense. B is going to be what drains lymph into your venous system. C is more of a lymph reservoir. And D is for used for fat absorption in your intestines. So, yeah, lymph nodes, right? So they're just the major filtration system throughout our lymphatic system. Number 12, the majority of lymph from the body drains into which structure before entering venous circulation? A, right lymphatic duct, B, cisterna chyli, C, subclavian vein, or D, thoracic duct? The majority of lymph from the body drains into which structure before entering venous circulation? A, right lymphatic duct, B, cisterna chyli, C, subclavian vein, or D, thoracic duct? Okay. And the answer is D. So, lymph from both of your lower extremities, your abdomen, your left thorax, the left head and neck, and the left upper extremity are going to drain into the thoracic duct first before then draining through your subclavian vein into your venous system, right? A only drains the right upper quadrant, and the others are, these two are irrelevant because it's got to drain into the thoracic duct before it can ever enter into the venous system through the subclavian vein. Okay, any questions about that? We can look up diagrams if we need to. Okay, we're going to move on. Number 13, manual lymph drainage is most effective when performed in which sequence? A, distal to proximal, B, proximal to distal, C, proximal clearing followed by distal drainage, or D, random pattern? Read it one more time. Manual lymph drainage is most effective when performed in which sequence? A, distal to proximal, B, proximal to distal, C, proximal clearing followed by distal drainage, or D, a random pattern? Wait for a couple more responses before we go. Okay, let's go over it. This one's kind of tricky, so maybe I did a bad job. Okay, in manual lymphatic drainage, you need to clear the proximal structures first, so that way distal fluid has somewhere to move. Okay, so the answer was supposed to be C, right? So we need to clear the proximal structures first. Yeah, clear the traffic jam, and then we move distal to proximal, right? So we clear all the proximal structures, and then we do distal to proximal, right? Mm-hmm. If we did just distal to proximal without clearing the proximal structures, uh, you may overwhelm those proximal collectors, and then you're not getting effective. Don't you do drainage starting with proximal structures, but drain in a distal to proximal direction? Yes, yes. So you start up high, distal to proximal direction, and then you start moving more distally to proximally, right? Does that all make sense? But you can't just go like, if we were doing, like if you're doing massage to try to get um, like venous return, like post TKA, for instance, we would start distally and just push proximally, right? But in lymphatic drainage, we need to start here, right, up high, clear those structures first, and then as we get that clearing, we start moving down, right? But we aren't going to just do, so my intention with this one with proximal to distal is I'm not going to just push proximal to distal, right? I'm going to clear stuff here and then go up. And then we're working proximally up and then distally up. If that made no sense, I apologize. I think maybe that was one of those questions that made more sense in my head when I was thinking of it. But either way, you guys get the spirit. Good thing this isn't your official test. Number 14. Which lymphatic structure collects lymph from the lower extremities and intestinal trunk before draining into the thoracic duct? A. Cisterna chyli, B. Thymus, C. Right lymphatic duct, or D. Popliteal node? Which lymphatic structure collects lymph from the lower extremities and intestinal trunk before draining into the thoracic duct? A. Cisterna chyli, B. Thymus, C. Right lymphatic duct, or D. Popliteal node? Okay, let's go over the answer. The answer is A, the cisternal chyli. So it's a dilated lymphatic sac that collects lymph from the intestinal trunk and lumbar trunks before going into the thoracic duct. So B is the site of T cell maturation, obviously. C is just the right upper body only. The right lymphatic duct only drains blood from the right upper body, right? And then your popliteal node is only going to do regional drainage. So drainage from one lower extremity up through that popliteal node, right? But not from both lower extremities. Okay, and final question about staging lymphedema. A physical therapist evaluates a patient with chronic unilateral leg swelling following pelvic cancer treatment. The swelling is soft and pitting, and the limb size reduces with elevation overnight, though it returns during the day with activity. Skin changes are not present. Which stage of lymphedema is most consistent with this presentation? A, stage 0, B, stage 1, C, stage 2, or D, stage 3? Okay, very good. Let's go over the characteristics of each stage real quick. So the characteristics of stage 1, you're going to have soft pitting edema that improves or resolves with limb elevation. You don't have any permanent tissue changes, and swelling can fluctuate throughout the day, right? With stage 0, or the latent stage, you may have a description of a person feeling like limb heaviness, and lymphatic damage will exist, but there's not going to be any visible swelling present yet, right? With C, your swelling is not going to resolve with elevation, and you're going to start the process of fibrotic tissue changes, right? And then D, you're going to have severe swelling. This is where we get to elephantiasis, right? You're going to have skin thickening, that hyperkeratosis, papillomas, and significant fibrosis. So good job on that one, guys. You guys seem to know your staging pretty well. Okay, those are the 15 questions for this week. We'll have another 15 ready for you guys next week. Let's see what the topics are. I'm kind of slowly working my way through these topics to cover, but next week will be non-systems, differential diagnosis, and then neuro, intervention and evaluation. Okay? We will slowly make our way through the rest of this list before the April boards. Are there any questions before we log off for the night? Hey, Desiree. Go back to book club. Oh, no problem, Gentry. I'm glad you got to be a part of the last little bit. Vonnie, no problem, dude. Nicole, I do this on Sundays at 8 p.m. Central Standard Time. I don't normally do this on Mondays. I'm just making up for missing yesterday. But, all right, guys. You guys have a good rest of your week, and I will see you on Sunday.